Assalamu alaikum, all my colleagues. I'm basically a pain physician, but my quest for treatment options available, which as a pain physician I can learn and do, kept me learning more and more. And in 2017, I had my fellowship from Korea from the Professor Gan Choi. All the neurosurgeons must be knowing him. He is world-renowned neurosurgeon doing the endoscopic spine surgeries. This is a disclaimer. Basically, the purpose of my talk is just to share what I know after traveling to multiple centers of the world who are doing the minimum invasive spine procedures there. Basically, this is what you guys should do and learn and spread in Pakistan. As you know, 85% of the population, since morning we have been talking about, they suffer from the low back pain, and problem is so frequent, and there is a limitation of the work output because of this. And in the long run, we have seen the surgery, all the interventions, compared to the patients who never had been treated, they are almost the same. So prevention is the best key for the betterment of our patients. There have been so many treatment options available, like selective nerve root block, epidurals. Selective nerve root blocks are very good as a diagnostic tools, as well as first option of treatment to give immediate relief to the patients. But results, maybe if it is mechanical compression, maybe results are not that good. And decompression of the disc is one of all those options, and Stryker they developed one decompressor also. I will show you that later. Nucleotomy, hydrodystectomy, nucleoplasties, laser dystectomies, ozone therapies, IDET, distraught, intradiscal radiofrequency, microplasty, endoscopic dystectomies, and minimum invasive spine fusion like TLEF, ELEF, and open surgery, microdystectomies, and laminectomy fusions. A long list of options. This is one picture showing the transforaminal epidural steroid injection for nerve root irritation treatment. And this is ozone therapy. Ozone therapy, it is being done successfully in many centers of the world to decompress a well-hydrated bulging disc. Well-hydrated bulging disc is very important for a good result for the ozone, but still FDA has not approved it in USA. Hydrodystectomy, 10 years back, it was one of the options to decompress the bulging disc, and many people have tried to do it, but later on, because of multiple reasons, they could not continue this treatment anymore. This is the Stryker decompressor, just to decompress the bulging disc, and intradiscal laser and IDET. IDET was one of the best options in the world for discogenic pain, as well as dural tears. When the tissue grows inside through the tear, and extra granulation tissue, as well as extra C fibers grow inside, and this used to be one of the best options, but unfortunately, due to the company's monopolies, people were discouraged to use it, but I tell you, technically it was one of the best options. Yes, laser used to be a good option also, but because of very high temperature, it caused charring of the end plates, leading to the non-pyogenic inflammation of the disc as well as the vertebra. So people have discouraged to use it now. Vertebroplasty and kyphoplasty is the gold standard up till now for the compressed fractures. Now I will talk about 3-4 new modalities which are being done with a very strong evidence all over the world. So I would like you people to learn it and do it for the best options and to increase the armament in your bag to treat every type of patients with minimum invasive procedures. Coagulation mean control ablations. You know, the low back pain is 85% people are suffering from low back pain, and out of them 39% have internal disc disruption. This is very important. So out of all low back pain, 39% people will have discogenic origin of the pain. Traditional management like medication, physical therapy, behavior management, psychotherapy, but in the recent years, general trend in spinal surgery has been towards the minimal invasive procedures and low cost. Nucleoplasty is a minimum invasive therapeutic option that has been used for spinal procedures since July 2000. What is the coagulation? Coagulation technique involves the radiofrequency energy to excite the electrolytes in a conductive medium such as normal saline, creating a 1 nanometer thick region of precisely focused plasma at the tip of the band. The energized particle in the plasma have sufficient energy to break the nuclear molecular bonds, enabling excision or destruction of the soft tissue such as nucleus pulposus. So hydrated disc must be there for effective treatment by this modality. The low temperature process are elementary particles which are breakdown like gases and water, and when we do this procedure, we see it exiting from the cannula. So it enables a gentle removal of the portion of the nuclear tissue, resulting in decompression of the herniated disc. This technique has two advantages. Number one, it will ablate the nucleus pulposus. Number two, in the second phase, it also causes shrinkage of the tissue. So this has very immediate effect also on the bulging disc, and is very easy to do, very easy to do. There have been so many studies, and they have found in 5 years that 63.4% at the 5 years follow had no pain. Advantages of is a low temperature procedure, 40 to 70 degree. It does not need any anesthesia, and trauma is very small, only 1 millimeter when we are pushing inside the annulus fibrosis, and patient can go the same day or the next day. If we cannot get results with this, other options can be tried on the patient, so there is no damage to the tissue because of this. Very simple equipment: C-arm, plasma surgical system, plasma band, and puncture needle. These are the four. This is the position we use for the patients, and this is the position of the C-arm. We mark the entry points. You must have heard the spine surgeons, they know the Campion triangle. Campion triangle, in 1973, Professor Campion College, he gave a good anatomical description of this safe area to enter the disc. So this green is the Campion triangle, and I don't go into details. So this is the target area we try to enter the disc, and this picture is showing AP and AP of the placement of the needle from the front and the back. So this is the lateral view. So this is the tunnel vision going into the disc through the annulus, through the Campion's triangle. And we do use local anesthetics. We don't need any sedations, but we have the safe markings also. In AP and lateral, we try not to go beyond the needle. The puncture needle should not go beyond the medial pedicular line. And in the lateral view, it should not go beyond 1/3 or 1/4. Minimum is that time is the distance we have to be inside the disc. There are many with the passage of your experience, you might be changing the entry point. Standard is 8 to 10 centimeters from the mid line, but maybe in some cases we go even from 12 also, 10. It's very safe because it is done under vision. We do under fluoroscopic guidance under vision. So, and they have made this band is a bit band, has a band in the front, so we can make a lesion at different places by rotating the cannula. I will show you. I don't go into the details like this. So this is the lesion we are creating. We go, first lesion we make at 12, then 2, 4, 6, 8 and 10 o'clock, and we create almost 1 centimeter square of cavity inside the tissue, which is sufficient for the decompression. So prevention of complication, yes. When we are inserting the needle, the most vital tissue we come across is the nerve root, and we warn the patient, if you feel any radicular pain, when we are close to it, just inform us. So if it happens, we either change the entry point or we change the direction of the needle, and when we touch the annulus, patient feels pain, we give local anesthetic over there, and then we enter the disc. And this procedure doesn't need any local anesthetic inside the disc. It's totally painless. But sometimes, due to if we retract the band too much and it touches the needle, then sometimes patient might have jerky movement in the muscles over there locally. So, and another important thing we avoid is we should not touch the needle, the band strip should not touch the end plates. Otherwise, it will cause inflammation over there, and maybe the procedure will have not good name in spite of good decompression. We take very strictly aseptic measures, just like we are doing open laminectomies, and we give intradiscal antibiotics, and sometimes we also engage with the normal screening. So this is the picture showing the L5S1 right side decompression, and this can be very successfully done in the cervical area also. Very good results for the bulging disc. Conclusion is nucleoplasty does not require general anesthesia, offers less morbidity and shorten the recovery time, contains herniated disc or focal protrusion are the most important inclusion criteria, as this technique is a promising tool and well selected cases. Next is very interesting talk. This is percutaneous lumbar extraforaminotomy, PLEF, we call it PLEF. I had this training in 2017 also in Korea, and Korean people are doing many cases with this PLEF, and only indication for this procedure is foraminal stenosis, when there is overgrowth of the facet joint, or there is buckling or overgrowth of the ligaments of flavum, or ligaments of the foramen. Only then they perform it very safely, very simple procedure. I show you. So this picture is showing all the anatomy of the intervertebral foramen. You all know very well, so I don't go. But important contents are spinal artery, ventral ramus, precriminating nerves, and medial and lateral divisions of the dorsal, primary ramus, and the veins. So, as you know, in radicular pain, if there is a disc herniation, if there is facet arthropathy and spinal and foraminal stenosis, surgical intervention is the only treatment of choice. But if it is the chemical substances, then the medical treatment and rehabilitation simple can help the patients. But they do both cause to worsen the condition for each other. So, target of what is target? Inflammation leads to edema, vasodilatation, adhesive fibrosis, that leads to the foraminal stenosis, the nerve and dysfunction and the pain. So another picture showing that inflammatory process, but impaired disc can lead to the impaired cartilage, and impaired cartilage lead to. In this, during my training for this procedure, I learned that the ligaments around the intervertebral foramen are very vital. They are very vital. We say, you have back pain, MRI is okay, X-ray CT okay, examination almost okay, but still you have pain. We do discography, patient can know it's not the important pain. Okay, we give the patient injection, patient can go, no, it's not the pain. So there is a percentage of patients with chronic low back pain who have problem with these small, tiny ligaments, which are causing that localized backache in these patients. So we cannot ignore these ligaments. So the most important ligament is the ligament of flavum and transforaminal ligaments, which we have to chop off during this procedure. So this classification of ligament of the exit zone, and these are the pictures which are showing different ligaments on cadavers by the slides. Just quickly go through because there are two more topics in my presentation. So, what is the role of foraminal ligament in the production of low back? If there is inflammation or due to the mechanical aspect, both ways they cause the low back pain in the patients. So, this is the grading of foraminal stenosis, 0 to 3. In 3, nerve root collapse occurs. This picture is also showing 0, 1, 2, and grade 3 foraminal stenosis here. And the factors for foraminal stenosis are ligamental thickening, disc bulging, facet hypertrophy, and disc collapse. So, surgical intervention, conventional technique, open fascectomy and fusion, open paraspinal foraminotomy, to controversies, unnecessary fusion, limited angle of vision, and post-op dysesthesia and instability. But if you do with the endoscopy, less traumatizing but challenging task. It's not easy, very long learning curve with the endoscope usually. So large diameter of endoscope in complete decompression can occur. For pain interventions, we sometimes give local steroids and visualizes. We do that with the transforaminal epidurals, but still maybe patient okay for some time, again they come back because it's mechanical issue with the patient. So I go to the complication. Direct then I show you the slides regarding the procedure, how it will be done. They have found that 82.2% had a good results up to 10 years with procedure, and only 19% of the patient had flares, which was settled after a couple of weeks, and none of the patient has any discitis or local wound. This is so effective foraminal decompression as well as successful anti-inflammatory treatment can lead to functional recovery of the intervertebral foramen. These are the 4 things we use for this procedure, PILAF. And I show you this newly launched kit. This is the complete kit having the 2 needle, anvil, and the cannula, and the trocar, and the curette. Very easy to learn, very easy to learn. Simply we target with our needle the superior articular process. We just go down, just give local steroid over there, then we push in the cannula, trocar I show you here. Very easy to do. So just see this picture. This is a central foraminal stenosis L4 and 5. This is the guide wire. We are just going there, infiltrating also. This is a 2E needle just in the foramen, even local anesthetic. Contrast is given there. Then on the lateral view, we check whether we are in the foramen or in the disc, because AP and lateral, they are more important to show the tip of the needle. Then the spread is right up to the upper disc as well. So then we slide in the trocar along with the needle, 2 needle, and then we put in the cannula, and the through cannula, if there is a big bulky fascial joint, we can very gently rotate this end mill, and this can softly we can make a way inside just by chopping off a small amount of facet and ligament. Then we put inside the curette. Is the same curette we use in our surgical? It's like that. And with the help of curette, we can just manually, under the flow guidance, we can nicely do it for foraminotomy like this. And I have treated few patients. They had excellent results. Their radicular pain, they had the facet joint hypertrophy and ligamental flavum, and they had very good results. And there was only 3 millimeter scar on the bottom. Very small. These are very tiny, small instruments. They are totally the Korean stuff. Then is there another modality people are using, especially in America. This is Invasive, we call it. This is only 3.5, 4.5 cannula we insert inside the disc, and this procedure is one of the best procedures with minimum invasion in the disc for the annular tear patients. Because if we go inside the disc, I have seen myself with endoscope inside the disc having annular tear, chronic annular tears. They have granulation there, and there the disc is even bleeding under vision. And they have a lot of growth of tissues inside, which are coming from outside in. So these patients, in spite of all treatment, they will not heal until and unless you remove the granulation tissue. So this effect is very good. You go there directly, you chop off that tissue, as well as you do the radiofrequency, and you ablate that area, you ablate the C fibers, ingrowing C fibers, and patients, they have very good results. But now, in advanced centers, now they go with a small endoscope also inside. It's only 3.5 millimeter endoscope, very small, long end. They'll just go inside and see on that, oh yes, you have healed it or not, you have treated it wrong. So just as evidence, you can see directly after this procedure. Then, very famous percutaneous endoscopic lumbar discectomy. This is very popular all over the world now, and Koreans are the leading people now in the world, because I was in the last activist in the May in South Seoul. The people coming from America, the big guys, even they were saying, oh, Koreans are doing better than us. And even the Japanese people, they were praising them. So this percutaneous endoscopic lumbar discectomy is one of the best options now being done by all the spine surgeons all over the world. So long history, it started with the Professor Cambion's first reports on the Cambion's triangle, leading to all that. Professor Gancho is also there, one of the interlaminar endoscopic discectomy foraminoplasty. He is there. So it has level 1 RCT. So this is the picture showing the anatomy of the Cambion's triangle, and this is the setup of the operation theater. In India, I have been to India many times. I have seen these procedures being done. Indian people, they do the marking of entry point on the patient right at that time under fluoroscope guidance, AP and lateral. That way they pay. And even in Germany, few centers they use the same. But in Korea, I have learned this thing. They do all their work on the MRI. Where to enter, which angle to use, and I have seen it. I have myself done it. That if you follow the instructions strictly, you directly go to the fragment you want to remove. So they spend a lot of time on these patients before they go for the surgery. This is the position. The Wilson frame is used for the good curvature for the patients. So laterally 12 centimeter, 13 centimeter, depending on the how fat is the patient. This is like this, and this is the angle of the 10 to 20 angles we go inside, and so when we go inside, actually important thing is visualization. Visualization is the most important word in lumbar spinal procedures because there are so much vital things are there. Dura is there, dorsal root ganglion is there, and nerve roots are there. So visualization, the more visualize you, the better you can perform. With open discectomies, open laminectomies, you have to make a big incision. You have to cut a lot of tissues. You have to cut the bone in and do laminectomy. And most of the patients may develop failed back sagittinum later or subluxation of the facet joints. But with microscopy and endoscopy, your vision is only tunnel visions, and you can see only limited, and you cannot maneuver the tube much. But with this endoscopy, per-training endoscopic procedures, you can see 30 to 40 degrees laterally with the scope by rotating the scope, as well as you can maneuver the cannula very nicely, very easily. So sometimes there is hypertrophy of the facet joints. You have to cut the facet joint with the bar or with the Tomshidi needle. You have to make a bigger hole. Yes, now there are two controversies. There is one group who says inside the disc, you look for the tear from where the bulge or the disc has gone outside, and you decompress the disc. You just make a bigger hole in the disc from where it has gone herniated, and then you pull inside the fragment. One school of thought says, but other one they say no. Why are you making two holes in one disc? The other, they go from the foraminal, they go transforaminal. Now people are converting to transforaminal because they have come to know going inside the disc unnecessarily is not going to help you much in the long run, and you will damage the disc more. You will damage even the normal part of the disc. So they go transforaminally and they just grab out the disc and they see directly the herniation area and they can ablate the area. So this way you can remove the fragments. I show you a few cases. This is a L4-5 central disc herniation before and after, and this is the axial view of the same patient. This is the up-migrated disc before and after, and in this there you see the traversing nerve and exiting nerve, they are compressed in this MRI, but it is removed and the foramen nicely open here on the right side. This is a down-migrated disc, very difficult. You have to do big laminectomy for that, and directly you can remove it with the help of endoscope. So foraminal HI, BD, they are very, very painful because they are directly compressing on the dorsal root ganglion. They are very dangerous as well to remove it because you cannot fix your cannula properly, and most of the time dorsal root ganglia also get injured. But if you remove it, patient has 100% relief. Another picture showing this is foraminal stenosis before and after the endoscopy, foraminoplasty, and this is SLR. You can see before and after. Now, you must have heard UB, unilateral bipolar endoscopic sublaminectomy. This is now people who were already doing perforated endoscopic lumpectomy. They have started learning this procedure now. Why? Because with the help of this PLD, you can go only on one side at one time. Otherwise, you have to go to the other side as well. But with the help of this unilateral bipolar endoscopic procedure, with one go, you can treat both sides of the spine at the same time. And the best thing about it is that this is very cheap. This is very cheap. The endoscope which I bought from Korea in 2017, November, it cost me $10,000 that time. Only one endoscope small. And whole set was around $20,000 that time. Very expensive. If you break or damage it, next to impossible, you can get it, you spend $5,000 more on it for repair. But with this UBE, you must have heard, you use the same arthroscope you are using for arthroscopy. Very simple. Maybe you are using the straight looking or 30-degree angle one. So this technique is used with this arthroscope, but you make two holes on one side and you treat both the sides of the patient. This is a patient I am just showing you here. I don't do it myself, but I have learned it. I have done the workshop on it as well. But I am just telling for your knowledge because this is, you can do it very nicely. Number two, one important point I will mention here is, in Korea and all over the big centers of the spine, people have 3 investigations for one patient. Plain X-rays, MRI and CT scans. They make sure that the bulging disc or the fragment is calcified or not calcified. This is very important. And plus they have additional information also from the CT scans also. So problem is degenerative central spinal canal stenosis and grade 1 spondylosis in this patient I have shown you. I show you. So we are going to show you the UBE sublaminoplasty. So simply on AP, we just mark the up and down of the disc we are going to treat are the foramen, and this is the marker, and this is the cannula we just put inside. This is, and simply we make two small holes, very small holes. One hole is used for your arthroscope and other one is used for your working channel. So you see with one hand and you work with the other hand. So this is very interesting topics for these guys because this is their domain. So with this arthroscope, you see inside everything. And with the other, you can do laminectomy, you can chop off the ligamentum flavum unilaterally, or the other side, you see directly with the arthroscope. And every theater with orthopedic facility has an arthroscope. So this is the position, so you can see how it is being done on the other side as well. So this is the same patient. There was no much cutting, nothing at all, and patient had wonderful relief. You can see pre-op and post-op MRIs. So surgeon prefer it because multi-angle vision, you can move it anywhere and very easy to learn. Very easy to learn. There is less bleeding, there is no scar on the back, only small those stitches. And other one thing is coming in the market, FDA, it is being waited for the FDA approval. This is called spine loop. I am just going to insight into you. Which, as you know, when there is hypertrophy of the ligamentum flavum, there is the buckling of ligamentum flavum when you straight. So when you stretch your back, flex your back, it straightens up and your symptoms are gone. But this buckling is basically the problem which is causing the spinal stenosis. For this, they have invented only two needles you put inside, and from one needle you get inside the bucket system. I will show you. And like this, and from the other you see put inside the wire, and you pull it quiet, and you just chop out like this, and you can remove the fragment from there. and it is still awaited for the approval from the FDA. So the take-home message is minimally invasive spine surgical procedure and treatments are the future of the spine interventions. Although the learning curve is long, but it is the need of the day and future for the physicians dealing with spine. Being focal person of ACMIST and COMIST in Pakistan, I can arrange training for the interested spine surgeon in South Korea. Thank you.